Thank you so much, Christine. It's a great pleasure for me to be here again after Corona, that we're live here again. It's really, yeah, I enjoy it a lot. Okay, so I will talk you through what's going on in the clinic regarding invasive lobular breast cancer. Well, first, of course, my disclosures. Well, what do we know? Well, probably you have heard this many times before already during these 2 days. ILC is just a morphological diagnosis, which means that it's just based on an H&E slide on the bottom. And the pathologist looks just at the slide and says, well, this is ILC. So that's it. But that's not a very precise diagnosis. And there are many differences between the standard form of breast cancer, so-called carcinoma NST, 70% of all breast cancers, and ILC. And I'm talking, if I'm talking about carcinoma NST, I'm talking about, in this case, ER plus, HER2 minus. ILC comprises 10 to 15% of all breast cancers. Imaging of ILC is suboptimal. The prognosis in the first 10 years is better, but the second 10 years it's worse than carcinoma of no special type. What we also know is that dual hormone substitution therapy has led to a rising incidence of ILC. Also, alcohol consumption is associated with ILC, and also an early menarche and a late menopause is associated with ILC. It has a different metastasis pattern compared to carcinoma NST, also called invasive ductal carcinoma. And it more often metastasizes to the GI tract, bone, and reproductive organs. And lastly, but not least important, the ILC molecular makeup differs from carcinoma NST. Specifically, of course, the hallmark of invasive lobular cancer, CDH1 loss. Now, in fact, we do not know a lot about ILC. We do not know whether we should treat it different in the clinic. So, in fact, we treat it largely the same as carcinoma NST, and I think this is a huge problem. What we do know is that we less often offer neoadjuvant chemotherapy to patients with ILC, and we offer less often breast-conserving surgery. Well, I think the first issue is the diagnosis. Currently, the concordance among pathologists based on just an H&E slide is suboptimal, and this was a very elegant study by Matthias Christgen and co-workers, where they did a so-called ring study. So they asked 35 pathologists to score the pathology on an H&E slide. That's the left side. And what you can see here in the upper thing is that dark gray means this is the real ILC diagnosis. And red is the pathologist who scored it like an ILC. And then they added immunohistochemistry for e-cadherin, the hallmark. And what you can see is that now it's a bit better, so because these are the 35 pathologists, and here we can see the agreement with the reference standard, and with only H&E, the kappa is 0.67, which is not too bad actually, but it's, well, there's room for improvement. But if you add the immunohistochemistry for e-cadherin, then it substantially improves to almost perfect agreement. So that's really nice, and I think this is something we should now, well, maybe of tomorrow, start to use in the clinic. Well, then, of course, there's still the debate on what antibody you should use, but I will leave that to the pathologists. Well, then a very important question is whether all early patients with ILC can forego chemo. And well, what has been done, and I think is very interesting, is genomic tests have have been run on both carcinoma of no special type and lobular. And this is a series of almost 600,000 patients from the SEER database, and they looked at invasive ductal versus lobular, and what you can appreciate is that the red block is the high grade, so high risk, and that's only 8% in lobular versus 18% in ductal. Also, MammaPrint results have been run in the MindTech trial, and here you see the comparison between ductal and lobular, and again you see that the high risk is much less prevalent among ILC. So that's good. But it's also true that if you have a high 21 gene recurrence score in ILC, then this confers a worse outcome. And this was shown in a recent study by Weisser and co-workers. And what you can see here is a Kaplan-Meier curve. And be aware, it's not till 0, but it's still 80% the survival. And on the x-axis, time in days since diagnosis. And what you can appreciate is that patients with an ILC with very low risk score, below 11, had a 5-year overall survival of almost 97%. Intermediate group, almost the same, 97%. But if you had a recurrence score over 25, it's 93%. So that's not as good. Well, the good news is that only in this series, only 6.6% had a high recurrence score. And in this series, 17.3% received adjuvant chemotherapy. Okay, well then the next question is, how does MammaPrint perform? And also for MammaPrint, what you can see here is that the low-risk ductal and lobular in green, they both have a favorable outcome, while if they are high risk, both lobular and ductal and lobular is the straight line, have a worse outcome. And here you can see the 5 years and 8 years survival estimates for lobular high risk. Well, then the next question, of course, is whether it helps to give chemotherapy if you have a high-risk recurrence score. And this shows, again, from the Weisser paper, the node-negative patients, both ductal and lobular, and the node-positive patients. And you can see here on the y-axis percentage, so how many patients received actually adjuvant chemotherapy. So in the low-risk group, that was really low, and it was a bit higher in the node-positives. But of course, the highest percentage of patients that received adjuvant chemo was in the node-positive high-risk group. It was a little bit less for lobular, that's in green, and blue is ductal. And this shows you the Kaplan-Meier curve of what the outcome is after chemo. And it shows you that in the node-negatives, in the lobulars, no chemo has a worse 5 years OS than chemo. So the absolute percentage is 5 years increases with 4.2% with chemo. And in node-positive patients, ILC patients, it increases, the absolute benefit increases with 12.2%. And if you do a multivariate analysis, then it only remains significant in the node-positive patients. But what it teaches us is that if you are not positive and you have a 21 gene recurrence score that is high, oh, sorry. I'm talking too close to the mic. I'll try to do better. So then what you can appreciate is that this is beneficial for node-positive ILC patients, chemo. Then another, I think, very interesting result from another paper from De Gregorio and co-workers showed that when they did a combined analysis of the success trial and the Plan B randomized controlled trial, and these trials investigated the use of taxane, then they found that in this group there were 726 ILC patients. Importantly, this was really a high-risk group. So 50% had node-positive disease and 40% had grade 3 disease. And this is for all patients, so not for the ILC specific. But what you can see here is that patients that had 4 or more positive axillary lymph nodes and received anthracycline-based chemotherapy, that they did much better than patients that did not receive anthracyclines, but just a taxane-based regimen. So what it shows here is that with the really high-risk ILCs, you should not omit anthracyclines. For the node-negative and 1, 2, 3 positive lymph node ILC patients, a taxane-based schedule without anthracycline seems to be as good. Now, of course, this is not a randomized trial. It is a post hoc analysis, but still, I think these are interesting data, and one might consider omitting anthracyclines in the lower risk ILCs if they are, for instance, genomically high risk. Then, what's also, I think, really fascinating, because I think most of us thought that chemotherapy was not useful in ILC in the early setting. And now we learn that in some instances, we should really consider it. And this is from the Oxford overview. And this is a paper that studied whether dose-dense chemotherapy, which means given once every 2 weeks instead of once every 3 weeks, or a higher dose of chemotherapy, whether that's better than the standard dose. And what was shown here is that both for the ductal, but also for the lobular histologies, it was beneficial to have more intensified chemotherapy. And this was based on 2,500 ILC patients. And there is a 19% relative risk reduction to die from ILC with dose-dense chemotherapy. So if you administer dose-dense chemotherapy, you should give it the best way you can. So that will be dose-dense. Well, then, of course, a very also important question, and it's gaining more and more interest, is whether tumor-infiltrating lymphocytes are present for the first question, are they present in ILC? So that's what Christine and co-workers investigated. And on the left side, on the y-axis, you see the amount of tumor-infiltrating lymphocytes, and here you see the groups. So this is all ILCs, and here you see the subgroup of hormone receptor positive, HER2 negative ILCs. And here, this is the subgroup of the triple negative or the HER2 positive ILCs. And what you can appreciate is that in this more pleomorphic ILC subgroup, the amount of TILs is higher than in the standard most prevalent ER plus HER2 minus subgroup. And they also looked in the big 0298 study. This was again a study that investigated chemotherapy, so these were more high-risk patients. And so immediately you can see that with more high risk, apparently there are also more TIL. What you can also appreciate is that the TIL level, median TIL level in the IDC is higher than in ILC. So in general, there's less tumor-infiltrating lymphocytes in ILC compared to IDC. And does that matter? What does it mean? And I think from this paper was also very interesting because they did not look only at the total amount of lymphocytes, but they also looked at where they reside. So they looked at whether they were intermingled with the tumor cells, and then you can see again that there were more TILs in the ductals than in the lobulars, or whether they were very close to the tumor cells, again, higher in the ductal than in the lobular. And here's the p-value for both. And for if they were more distant, further away from the tumor cells, there was no difference. So how this has been interpreted is that maybe the lobulars are not very immunogenic, or they secrete a factor that prevents the TILs to reach the tumor cells. But we don't know exactly. And this is in fact a sidestep, because this is a study that was not done in ILC, it was done in all subtypes. And it was a study run in the Netherlands. And they investigated in over 600 patients whether adjuvant 6 times dose-dense AC was better or the same as 6 times TAC. And that was not the primary endpoint of this study, because it was assumed that both regimens would be equally effective in high-risk early breast cancer patients. What the goal was to generate gene expression profiles of each tumor of each patient, and then afterwards use algorithms to tease out the patients that would benefit more from dose-dense AC and what patients would derive more benefit from TAC. TAC is with a taxane. And indeed, there was no significant difference between the 2 regimens if you take just the whole group, each arm, all patients together. Then the 5 years overall survival was around 93%. And of note, 81% of patients had node-positive disease, so it was really a high-risk group. Now, what was done next was the group of Jacob van Reenen in our institute developed an algorithm called tumor cell deconvolution. And he did that by using breast cancer cells, single cells, derived from early breast cancer tumors. And he generated a gene expression profile for each cell type. And so then he developed a catalog of cell type reference gene expression profiles. And then he used the bulk tumor RNA sequencing from each tumor from patients who had participated in the Matador study. And he asked the computer, tell me what cell types are present in this particular tumor from this particular patient. And so then they could, based on the computer, define for each tumor what the percentage of each cell type was that contributed to the whole tumor. And then they developed a delta treatment score, is what they called it, a DTS. And they could find 2 groups, a DTS low group and a DTS high group. And what they found was that in the DTS high group, there were a lot of T cells in the tumors. And the majority of the DTS high group was triple negative. And then they asked whether this DTS score could tell what regimen would be more beneficial. And on the y-axis, you see the log relative hazard between the 2 treatments. And the lower the line, the better the outcome. So what you can see is that when the DTS score on the x-axis, when that rises, then TAC is much more beneficial than dose-dense AC. But when the DTS score is 0 or less, then there is no difference between the 2 treatment groups. And so what it means is that when there is a tumor with moderate or high TIL, then the addition of a taxane probably is beneficial. And it can be pretty, impressive, the benefit. But if there are no TIL, then the addition of a taxane won't add. So when we go back to the data from the other study, that a anthracycline-free schedule is not very beneficial for lobular breast cancers, especially the high-risk lobular breast cancers, this might mean that those tumors have less TIL or almost no TIL. And therefore, leaving out an anthracycline is maybe not a very good idea. But this is just hypothesis generating. We have no idea. And what we need is the TIL scores from the German studies, the SUCCESS and the Plan B studies. So if we wrap up all this information, what we can conclude is that if there's stage 3 disease in ILC, then patients should be treated with anthracycline-based dose-dense chemotherapy. If there are if they're stage 1 or 2 disease, and it is hormone receptor positive, HER2 negative, then when there's a genomic high risk, according to MammaPrint or Oncotype DX, chemotherapy should be considered, especially in node-positive disease. And when the tumor, the ILC is triple negative or HER2 positive, then we know from recent studies that these patients should just be treated like ductal carcinoma. But still, I think a biomarker for chemotherapy benefit in ILC, stratified also by menopausal status, is something that we do not yet have. So there's still a lot to be done. Now let's turn to endocrine therapy, of course, for the hormone receptor positive ILC. This is a study by Otto Metzger and co-workers already some time ago. And what they did is they did a post hoc analysis of the Big 198 study. And this was a study in postmenopausal patients where they randomized patients to either 5 years of tamoxifen, 5 years of letrozole, or a switch. So either 2.5 years TAM and then 2.5 years letrozole, or vice versa. Now he looked at the patients who either received 5 years of letrozole or 5 years of tamoxifen. And the total group was 2,900 patients. And the lobulars in this group were around over 300 patients. And what he observed was that in lobular breast cancer patients, letrozole was better than tamoxifen. And you can read this in this graph. This is a forest plot, and this is the hazard rate. If it is 1, it means that there's no difference between letrozole and tamoxifen. But if this square is on the left, then it means that in this case letrozole is the best treatment. I think there have been some other studies, but generally I think you will never do wrong if you start with an aromatase inhibitor in patients with hormone receptor invasive lobular breast cancer. Now again, let's have a look at those TILs again. So what we know is that they are lower in general in ILC. And there has been a post hoc analysis from the TEAM trial, and it was also a trial in postmenopausal breast cancers. And it compared 5 years of exemestane versus 2.5 years of tamoxifen, followed by 2.5 years of exemestane. And here they truncated the follow-up at 3 years. So in fact, effectively, they compared exemestane with tamoxifen. And what they found, and again, it's hypothesis generating, but I think it's very interesting, is that if there are low CD8 TILs, the most important TILs, then exemestane is better than tamoxifen. That's a significant finding. While if there are high TILs, then it doesn't matter. You can either give an AI or tamoxifen. Well, I think this is just not, we cannot use it as of today, but also when we look at the other study from Otto Metzger, I think it is safe to offer an AI in postmenopausal patients with ILC. It's the safest. It's difficult. I'm not so good in this. I usually have the thing with that I don't have to do this. Sorry for if you can't hear me or whether you hear me too loud. So the next question is, how long should we give hormonal therapy? And this, I think, is also a very interesting study from Mitch Dowsett. And what they did is they combined patients from 3 studies, 2 Austrian studies and 1 from the UK. And they looked for the ILC patients in those studies, and they could retrieve 470 postmenopausal ILC patients. 31% of these patients had node-positive disease. 94% had less than 5 centimeter large tumors, and only 3% was grade 3. So in general, this was a moderate low risk group. And none of these patients had received chemo. They had only received hormonal therapy. And then they ran a genomic test called EndoPredict, and they combined it with clinical data, and they looked at the 10 years distant recurrence-free survival. And what they found was if the patient has an EP clinical low score, then there is a very favorable outcome at 10 years. There's less than 5% distant recurrences, and that cannot be much improved by extending endocrine therapy beyond 5 years. While in the patients that have high risk, there's a considerable risk of a distant recurrence at 10 years. So this group should be considered for extended hormonal therapy. And again, this should in fact be prospectively confirmed, but I think it's already very useful information. Now then the next question, I think also very important, because the large majority of ILCs is hormone receptor positive, is what might cause endocrine therapy resistance. Well, and there are many potential factors, and I only listed, well, just a few of them, but I think some of them are very important. So the first one is you can get receptor conversion, so the receptor just get lost. Then age can be a factor. Then additional activated growth factor pathways like HER2 mutation or HER3 mutation or PI3 kinase pathway activation, which I'll come back to that later. Well, we already discussed the immune system. Then genes that are involved in cell cycle regulation, and also epigenetic ER-alpha modifications can also cause resistance. So let's turn to the MAP kinase and the PI3 kinase pathway. There are many ways that these pathways can be activated, and this is just a, well, it's not an exhaustive list, but I think these are pretty important molecular aberrations that can occur in ILC. Now, can we measure the activation status of these pathways? Well, in my lab, several PhD students worked on this, and this is really cumbersome because phospho-specific antibodies on FFPE material is not very robust. Yet, we gave it a try. So we used several phospho-specific antibodies. And you can, well, I don't know whether you can read it here, but most important is that you want to know whether they are phospho-specific. And you can test that by using lambda phosphatase. You treat the slides with that, and then all the phospho groups vanish. So here they are stained in brown, and here they should all be gone. And the same here, all brown, and here they should all be gone. So we were pretty happy with these results because it looked pretty good. P10, by the way, we just measured overall P10 presence, so not whether it was phosphorylated. And we did this in a post-hoc unplanned analysis of the Dutch IKA trial. Patients were diagnosed between 82 and 94, so really long time ago. And they were all postmenopausal, and they were randomized between nothing, is unimaginable now, these days, or tamoxifen, 30 mg per day, in a pretty strange schedule we would not use today. And then after 1 year, the group that had received tamoxifen was randomized again to continue for another 2 years of tamoxifen or stop. And what we did, we tried to retrieve all the tumor blocks, which was not easy, and we did not retrieve all, but we still retrieved, well, around 300 blocks and of patients that had a hormone receptor positive, HER2 negative tumor. And these were all comers, so not only ILC. Because at that time, they treated all postmenopausal patients with tamoxifen, no matter whether it was hormone receptor positive or negative. And so we stained all these different components of the PI3 kinase pathway, and we used an algorithm to define whether the patients had an activated or non-activated pathway by hierarchical clustering. And so then we got two groups, one group of mainly activated tumors that had mainly activated PI3 kinase pathway, and tumors that had mainly not activated. And when we then looked at whether tamoxifen was beneficial, then it was very beneficial in the group that had predominantly non-activated pathway, while it was not effective in the activated group. So, well, at least this confirmed what was already known for a long time in preclinical experiments, that activation of the PI3 kinase pathway confers resistance to endocrine therapy. And then we looked at IGF-1R, because also from preclinical studies we know that IGF-1R may be upregulated due to loss of E-cadherin. And so, again, we used immunohistochemistry with a phospho-specific antibody. And what we found was that patients who had IGF-1R activated, that these patients did not benefit from adjuvant tamoxifen. So I was very curious about the outcome of the UNICANCER trial, where they studied whether the addition of everolimus, which is an mTOR inhibitor, but in fact blocks the PI3 kinase pathway, whether that would be beneficial in the adjuvant setting in combination with hormonal therapy. In total, over 1,000 patients were entered onto the trial. Unfortunately, they did not do a subgroup analysis for invasive lobular breast cancer. And these were pretty high-risk hormone receptor positive HER2 negative patients. And patients could still enroll in the trial if they had already received up to 4 years of single-agent endocrine therapy. And then we randomized between 2 years of everolimus added to endocrine therapy or placebo. And this graph shows you with a median follow-up of 36 months, which is very early for this subgroup of breast cancer patients, that there's no difference. And so the trial was stopped. So, yeah, it's a pity. But of course, they did not look at what patients had an activated PI3 kinase pathway. But from the other study in the old Dutch trial, there was almost 40% that had an activated PI3 kinase pathway. So I guess that maybe a substantial proportion here should have had also an activated pathway, yet everolimus did not work. So now the question is whether this approach might work in patients with ILC specifically. Because what we do know is that around 50% of patients with ILC have IGF-1R expression. And you can see that in the graph here. So in IDC, the large majority has no expression of IGF-1R, but in ILC it's around 50%. What we also know is that several genes in the PI3 kinase pathway have a mutation in ILC, and that's over 50% if you look at PIK3CA, ACT1, and PTEN. So maybe such an approach would be beneficial in ILC. Now, let's turn to a completely different tumor type, and this is colorectal cancer. And this is a paper already from 2012. So they had thought that because in melanoma, BRAF inhibitors are very effective. So they thought, well, maybe they will also be very effective in colorectal cancer. But what they found was that if you use a BRAF inhibitor in colorectal cancer cells, and this is the MAP kinase pathway, the BRAF, then that doesn't work because you get upregulation of EGFR. And so what they did is they thought, well, if we block both BRAF and EGFR, and it's shown here in xenografts that are BRAF mutated, that might be useful. and might reduce the tumor volume. And indeed, the combination of EGFR blockade and BRAF blockade was very beneficial. And recently, well, in 2019, the landmark trial showed indeed that this approach was also very effective in colorectal cancer patients, metastatic cancer patients. So the overall survival increased, the median overall survival increased to 9 months compared to 5.4 in the control group. And these were patients that were already heavily pretreated. And on the right side, you can see the waterfall plot of the amount of patients that had a response on this triplet or doublet therapy compared to standard. So based on this paper, but also many others, and I cannot discuss all papers because so many great papers came out lately, but shows that the loss of E-cadherin enhances IGF-1 and IGF-1R signaling, and also sensitizes breast cancers to inhibition. So, oh, and now what happened? Oh, yeah. So the question that I have is, shouldn't we not test this combination also in breast cancer? In patients, in lobular breast cancer patients that have a PIK3CA mutation, ACT mutation, or PTEN mutation, we inhibit the gene with the mutation or the protein with the mutation, but probably there will also be an increased expression of IGF-1R or maybe one of the other growth factor receptors trying to overcome that inhibition. So the idea would be to do also a doublet or a triplet. And maybe this would also be very effective in ILC. So I would advocate to start such a trial. There haven't been many trials focusing on ILC specifically, but there have been at least 3. And maybe there are new ongoing, I don't know, but I'd like to hear. And the first one is the Poseidon-1 trial, but this trial unfortunately stopped early and never started in ILC specifically because of COVID. So there will never be data specifically for the ILC subgroup. The second trial has recently been finished. In fact, this is the first trial in metastatic ILC specifically with results. And this is called the Gelato trial, and there they combined immunotherapy with carboplatin AUC 1.5. And I will come back to that in a minute. And the last trial is a trial where they inhibit ROS1. And I think the trial is still ongoing. But well, a little bit more about the Gelato trial. So the idea here is to find the so-called hot tumors among the cold, because ILC tumors are generally cold. Well, the second question is, can we treat with anti-PD-1 or anti-PD-L1 only without chemo? And the Gelato trial was based on 2 landmark studies, one from Ciriello et al. In Cell, and the other one from Michaud in Scientific Reports. And they studied the molecular makeup of ILC. And what they showed in both papers is that there is an immune-related subgroup of ILCs. So the underlying hypothesis was that within Gelato, these patients would benefit most. Well, this was the setup of Gelato trial. So it started with platinum. So at time point minus 2 weeks, 2 weeks of platinum only, AUC 1.5, and then the atezolizumab 1200 milligrams once every 3 weeks was kicked in. And so then for 9 weeks there was combined treatment with, well, no, it's 10 weeks, by the way, carboplatin with anti-PD-L1. And then after 12 weeks, there was continuation with mono immunotherapy. And the main inclusion criteria were metastatic ILC. If it was hormone receptor positive, it should be endocrine treatment resistant. There should be lesions available for biopsy, and this may have skewed the patient selection. And the maximum 2 lines of palliative chemo were allowed. A good performance status and a low LDH, because with a high LDH, there's no benefit from immunotherapy. And the statistics, the primary endpoint was progression-free survival at 6 months, and it was a Simon 2-stage design. And 3 out of 22 patients with at least 6 months being progression-free was considered a success. And these were the results. So there were 21 evaluable patients, and the objective response rate, so complete remission plus partial remission, was 19%. And the clinical benefit rate, so at least stable over 6 months, was 29%. And there were 4 partial responders. So the trial met its primary endpoint. And this is the swimmer's plot. Here on the x-axis is the time in weeks. And what you can appreciate it here is 24 weeks, is that 4 patients were longer than 24 weeks progression-free. And I don't know whether you can see it, but there's 2 colors in the graph, and the green is the triple negative. So what you can see is that 4 out of 6 patients that had a stable disease or partial remission were triple negative. And so although this trial met its primary endpoint, the idea was mainly that we could use this approach in hormone receptor positive, HER2 negative ILC patients that had this immune-related signature. I don't know whether I can tell this, but the immune-related signature did not help to select the patients. And so, in fact, what we have established, and I think it's also very important news, is that immunotherapy is very efficacious also in triple-negative breast cancer patients that have the ILC morphology. So I think that's important. And I think it's also very important that the team managed to complete this trial. So again, it is the first trial in ILC, and the majority were triple-negative breast cancer patients. And another thing that I did not show is that after carboplatin, because the idea was to make a cold tumor hot by pre-treating with 2 weeks of carboplatin. But what we learned from the biopsies is that it didn't work, this approach, in ILC. Now, then is another very important question, is whether we don't know, there have been pivotal trials establishing usefulness of alpelisib in metastatic hormone receptor positive HER2 negative breast cancer and CDK4/6 inhibitors in metastatic hormone receptor positive HER2 negative breast cancer. But there have been no subgroup analyses for ILC patients. None in SOLAR, none in Sandpiper, not in Mona Lisa, and not in Monarch. But the good news is that we recently got this abstract at ASCO from MD Anderson, Moabi and co-workers, who looked in their huge database at MD Anderson and identified metastatic patients who had received hormonal therapy plus CDK4/6 inhibitor. And they identified almost 2,000 patients. Around 1,500 had IDC, but 277 had ILC. And he compared the PFS on this combination between ductal and lobular. And the good news is that in ductal it was around 12 months, and in ILC it was almost 15 months. So what we can conclude here is that at least it's not less effective in ILC, and maybe even a little bit more effective. But that was not significant. He also studied the addition of everolimus to hormonal therapy. 1,000 patients, 843 in ductal and 141 in ILC. And again, there was no difference in median PFS. So also everolimus is as effective for ILC patients as it is for ductal patients. And finally, alpelisib plus hormonal therapy, and I think there the numbers are really low, 49, so we cannot conclude a lot. The median PFS was 5.2 versus 3.0 months, and it was not significant, but I think here we need really larger numbers. So that brings me to the almost final slide, because I really would like to present you the follow-up study of the Poseidon study, and that's called the Poseidon to lobular study. And here are the key eligibility criteria. Patients should be 18 years or older, have hormone receptor positive, HER2 negative ILC, and it should be defined by loss of E-cadherin with immunohistochemistry. There will be central testing of PIK3CA, ACT1, and PTEN. And this will be done on circulating tumor DNA and will be done by Foundation Medicine. So they will test many more genes, but these are the ones that we will use for stratification. Patients should have evaluable disease. That's different from measurable. Evaluable means that it may also be non-measurable, but there should be some feature so that we can evaluate whether the treatment works. Patients should have no more than 2 lines of hormonal therapy and 1 line of chemotherapy. The randomization is 2 to 1. So 2/3 will receive tamoxifen plus an ACT inhibitor, and the other 1/3 will receive tamoxifen plus placebo. And these are the stratification factors, so the mutation, yes or no, in one of these genes, whether there's earlier chemo, yes or no, and visceral versus non-visceral metastatic disease. And the primary endpoint is progression-free survival, and there are many secondary endpoints that are not so easy to read here, but they are about, of course, about safety, but also about PROs. So what we will use is an app, a PRO app, and if patients do not have a cell phone, they can use paper, but of course the advantage is the cell phone. And patients can then also, if they have complaints, they can just use the app to communicate it to their physician. And so the toxicity will be much better monitored than by standard visits. And also I think it will be very useful because usually you forget about toxicity. If you feel fine again after 2 days, you forget that you had some toxicity. While if you use that app regularly, we can also look back and see, oh yeah, but you had 3 days of diarrhea or you had 4 days of headache. So I think it will be much, much more precise. And also, and I forgot to mention, we will do also a lot of imaging because an issue with metastatic ILC is that it's very difficult to monitor. So we will do MRIs, we will do in a subgroup PET CTs, we will do even a metabolic measurement using MRI. So yeah, it will be a study where we hope that we will really learn a lot, and hopefully also it will be really effective for ILC patients. And that's what, well, several people here in the audience think. But we'll see. Well, this brings me to the conclusions. In the neoadjuvant setting, patients with stage 3 ILC and triple negative or HER2 positive ILC should receive the same treatment as for ductal carcinoma, as for now. I think there we have a lot to do. In hormone receptor positive HER2 negative ILC, well, we can now consider genomic tests to guide adjuvant chemotherapy, and we can also consider other genomic tests to decide on the duration of endocrine therapy. And I think in postmenopausal patients with ILC, you should always start with an aromatase inhibitor. Yeah, in a metastatic setting, I think we really should continue to develop ILC-specific trials, really based on the molecular biology. And yeah, I'd like to go to hear also from the audience whether you have ideas for other trials, because I just showed you one, and I mean, there's not a lot out there. We have to do, there's much more work to do. So yeah, that's where I wanted almost to stop. Well, these are the acknowledgements. Of course, you always work together with many, many people, and even this is just a fraction of all the people that do so much hard work. And of course, and I think it's, I don't know whether it's on the slide, but of course the patients who are willing to participate in trials is so valuable and so also courageous, I would say. Yeah, but I think the people that I'd like to mention specifically is Leonie Voorwerk, who ran the Gelato trial, Marleen Kok, Patrick Derksen, who discussed in the early days the Poseidon to Lobular trial with me, and so many people. Yeah, Christine, I would like to mention specifically, and Matthias and Anne, and of Showan, and Rian. I don't know whether she's in the audience. She's not, no. And then I'd like to show you one movie that I really like, and I think this is the movie that well, it also symbolizes us, because the first person who started calling ILC is Stewart and Foote. I learned from Matthias in 1941. And it starts with some person who thinks, oh, let's do it different. And yeah.
If you've learned a lot about leadership and making a movement, then let's watch a movement happen, start to finish, in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore. It's about them, plural. Notice how he's calling to his friends to join in. See, it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not two nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers, because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute, you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is overglorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.